we welcome to the Maryland Healthcare Commission meeting. Do we have any commissioners on the phone right now? None. I will begin the meeting by noting with sadness the passing of Congressman Cummings earlier this morning. No prepared remarks around that at this time, but obviously his commitment to the state of Maryland so many ways will sorely be missed. Commissioners have any thoughts, comments to share?
Calling the giant of Baltimore. The giant has fallen. We should honor him. I know that one of the very important issues after the death of Monty Driver, the young boy who died of a toothache, and Cummings was instrumental in the legislation and now provides good care for our kids.
Certainly is. Our first item of business today will be approval of the minutes. I'll now entertain a motion to approve the minutes of the September 19, 2019 public meeting of the Commission. Do I have a motion? So moved. I have a motion and a second. Second. All in favor? Aye. All opposed? Hearing none. The minutes are officially adopted. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Hearing none. Seeing none. Does the executive director or any of the center directors have any additional updates? Mr. Executive Director.
Thank you, Mr. Chairman. So I have a couple of announcements and pieces of information. First off, in terms of information, I wanted commissioners to know that our financial assessment of Chestertown Hospital being conducted by LD Consulting is on schedule, and we expect to have a report to you in December. We will ask the consultants to review the financial assessment results with Shore Health and representatives of Chestertown prior to the December meeting. MHCC, in collaboration with HSCRC, held a kickoff meeting with the Walsh Center at the National Opinion Research Center at University of Chicago for the models study on the Chestertown rural health issue. The Walsh Center will look at models of rural health delivery that are consistent with the overall total cost of care model that the state signed in July of 2018, but are especially effective for smaller rural communities in Maryland. We will convene our first Maryland Primary Care Advisory Council meeting on October 22nd. Dr. Michael Reedman, President of Maryland Primary Care, and our own David Sharp will be co-chairs of that group. We have a very capable advisory council that will make recommendations to the health secretary on the evolution of the primary care program in the years going forward. Last month, I let you know that the work group on acute inpatient psychiatric services had gotten input from stakeholders and members of that work group that a pause might be advisable to get additional clinical input on the types of patients that were particularly hard to place in Maryland psychiatric facilities. There's lots of work going on in this area, and we have begun the work of convening this clinical panel that would bring together psychiatrists and other behavioral health experts from the respective special psychiatric hospitals, as well as general their assessment of patients that pose special challenges to placement in the existing facilities here in the state. Once we have that input complete, then we intend to reconvene that work group informed by that input and complete the revision of the state health plan chapter for inpatient psychiatric services. What that does mean is we're not going to meet our deadline of completing chapter revision by December of 2019. So we will have to submit a report/letter to the respective committees explaining the delay. We would expect that the MHA and other groups would also join us in emphasizing that although the plan update is delayed, it's going to be a delay that will lead to improvement in the final product. Lastly, last month I talked about a surprise communication we had gotten from insurance companies, a contract with the federal government as part of their federal employee health benefit insurance products. Those carriers had told us that they could no longer submit claim information on federal employees, their dependents, and retirees to the Maryland Medical Care Database, also known as the Maryland All-Payer Claim Database. This has a dramatic impact on the completeness of the data. Federal employees and their dependents represent about 22% of covered lives in this data system. And it makes the credibility of results from that data weaker because of the loss of this important data feed. I have prepared a letter to the Director of Health Services at OPM, requesting them to review that decision. And I have submitted to the governor's office just to give them a heads up that we are communicating directly with OPM on this important issue, not only to MHC, but to HSCRC as well. That concludes my.
Very good. Do any of the other center directors have anything?
So I have a new employee, Mr. Shankar Mester. He will be the new chief of course and quality. Mr. Shankar comes with over 10 years of experience in claims and data analysis. And we are very, very happy to have him here. He has a master's degree in public health and also has a medical degree from India. So we're very, very happy and excited to welcome Shankar aboard.
Thank you so much.
Thank you.
On to agenda item number 3, certificate of need, Upper Eastern Shore Home Health Agency review. The Commission has 2 certificate of need actions on today's agenda. The first is a comparative review of applications to provide home health agency services in the Upper Eastern Shore region, which consists of Cecil, Kent, Queen Anne's, Caroline, and Talbot counties. 3 applications were docketed in this review. 2 of the applicants, Medicis Maryland and Beata Home Health Care, are existing Maryland home health agencies that seek to expand their authorized service areas to include jurisdictions on the Upper Eastern Shore region. And the 3rd applicant, Optimal Health Care, is an existing provider of residential service agency care that's qualified to seek approval to become a provider of home health agency services. Representatives from the 3 applicants are here with us today. They are from Medicis, Todd Edgecombe, VP of Operations, and Marta Harding, Counsel. From Beata, Michelle Heasley, Director of the Harford County Beata Office. From Optimal, Dillis Minang, Director of Clinical Operations, and Carla Robeson, Director of Marketing and Business Development. Thank you. Commissioner Marcus Wang has served as reviewer for this matter, and he will present his brief recommended decision for consideration by the full commission. Commissioner Wang.
Thank you, Mr. Chairman. The chairman emphasized brief, so I won't take more than 2.5 hours, I promise. This is why all the commissioners have fled today. So first of all, I had a birthday recently, and celebrating that birthday reminded me of my advancing age, approaching senility and decrepitude that awaits me. So home health agencies are now very dear to me. So today what we have are applications by three, Medicis, Beata, and Optimal. And these home health agencies want to expand into the Upper Eastern Shore region of Maryland, just Caroline, Cecil, Kent, Queen Anne's, and Talbot counties. So we're looking at the need, first of all, and there's definitely need in those jurisdictions. In Caroline and Kent, they have insufficient numbers of HHA providers, which is defined as 2 or fewer that serve 10 or more clients in each year of the preceding 3 years. So that applies to those counties. There's a need. In Cecil, Queen Anne, and Talbot counties, they do have a sufficient number of competing HHAs, but there is a lot of concentration where only two dominate the market, according to the Hirschman Index. And it's also, I want to note that the original deadline for this application was in January 2017. And notice it went out. We only had one applicant, VNA of Maryland, and they applied by the deadline. They got their CON by July that year. And everything was hunky-dory, except the Maryland National Capital Home Care Association then reached out and said, and lo and behold, they had no idea of the deadline. And if they had known, they would have told their members to apply. So I want to take a look into that because that's serious. Turns out our commission staff went above and beyond to make sure that notice was given to everyone, including the Maryland National Capital Home Care Association. And it did turn out the ball was dropped on their end. But since we're not about blame, we're about serving people in Maryland, I'm very proud to say the commission staff took it upon themselves to reopen the application process. And in doing so, they approached VNA and got VNA's consent to waive the 3-year waiting period for the next round of applications. And so the commission staff really did this because it's what's in the best interest of people in Maryland, to have more access to quality health care. So I just wanted to really commend our commission, our staff. People say government agencies are inflexible and bureaucratic, and that's often true. They're applying for driver's license, but not with the healthcare commission. So in terms of need, in terms of viability and impact, the staff has reviewed all the relevant criteria under the law. All three meet those criteria. And therefore, we want to go ahead and recommend the CON be approved for all three applicants for their expansion into the Upper Eastern Shore of Maryland, with, of course, conditions. We never let them go without conditions. So number one, to maintain compliance with provisions of Comar 1024-1608 E1-4 regarding charity care, sliding fee scale, and reduced fee services. Number two, to provide a level of charity care equivalent to or greater than the average level of charity care provided by home health agencies in the area to which it's expanding. And that's Caroline, Kent, Queen Anne for Medicis, Cecil for Beata, and Caroline, Cecil, Kent, Queen Anne, Talbot for Optimal. Number three, prior to request for first use approval, all three provide documentation of the links with hospitals, nursing homes, continuing care retirement communities, hospice programs, assisted living providers, adult evaluation review service, adult daycare programs, local department social service, and home delivered meal programs located within the approved expanded service area. I saw the chairman giving me a look. Finally, the certificate needs issued to Medicis Salisbury. We want to have it contain one more additional condition. 4, and this is important, that the Medicis shall serve clients whose payer source is Medicare or Medicaid or private insurance or self-pay when they're providing these services to their clients in Caroline, Dorchester, Kent, Queen Anne, Somerset, Talbot, Wycombe, and Worcester counties. And they shall not discriminate on the basis of patient's payment source when they're providing home health agency service to any patient. Sure.
Thank you. Before we initiate discussion, do I have a motion to approve the certificate of need application filed?
So moved.
Second. Motion and a second on the floor. Discussion. Thank you for that outstanding summary. Comments from commissioners? That was serious. Commissioner Brady's not here, so the discussion seems to be dramatically abbreviated. He took a shot at the NBA. In that case, Absent any objection, I'll take a vote. Is there all in favor of approving the recommendations of Commissioner Wang?
Aye.
All opposed? Rapid and unanimous approval. I believe you have some additional remarks.
Yes, some additional remarks very quickly, but just want to make a suggestion to Amedisys. Congratulations to all the applicants. Regarding your acceptance of non-Medicare payers in all 7 of your Maryland HHAs, I noted that in the 5-county service area, you've improved your provision of HHA service to clients who are not insured by Medicare, including Medicaid and private insurance and self-pay. So your number has improved from 2014. Only 4% of your clients had commercial insurance, and under the preliminary data of 2017, that's risen to 6.5%. That's a great improvement. But the other HHAs serving the 5 counties provide 22.2% of services to clients insured by commercial payers. So Amedisys software is improving tremendously. We haven't passed a condition regarding non-discrimination that was just adopted, requiring that you not discriminate on the basis of the patient's payment source when providing home health agency service to any patient. And for Amedisys Maryland, who has 7 HHAs licensed in Maryland, there's a Maryland-specific shared care policy, and I would like to see Amedisys Maryland adopt a Maryland-specific policy regarding requiring the same non-discrimination based on patient's payer source. In 2017's data, Amedisys Maryland HHAs serve 14 jurisdictions, and of those 14, only about 6.17% of Amedisys clients were non-Medicare. 6.717%. The other HHAs in those same jurisdictions, 30.2% of their clients were non-Medicare. So there's a big discrepancy there. I'm sure there are good reasons for it, Marta. I just want Amedisys to please note that discrepancy. Please address this matter, and the commission staff to inform the commission annually on how the Amedisys Maryland LLCs are doing in serving non-Medicare clients. And hopefully, I'd like to recommend that when we adopt the next update to the HHA chapter, the commission could review and address this issue of discrimination based on payer source. And it could be the fact that database and demonstration of non-discrimination should be a qualifying factor when folks apply for us.
Arundel, do you want to comment?
Yes, just very briefly. Thank you, Commissioner Wang, for your time on this. We actually are close to 10% or more this year, so we're on the rise, and we are absolutely don't discriminate in any of our agencies across the state, and are happy to accept the condition and report as you would like. Thank you.
Thank you. Thank you again, Commissioner.
And thank you very much to the staff, to Kevin and Laura and Sue Ellen and Kathy West. Kathy did a really great job digging.
Thank you. On to agenda item number 4. Certificate of Need, Cadencia, Crownsville, Establishment of Alcoholism and Drug Abuse Treatment Intermediate Care Facility. Our second CON action today concerns the establishment of a 27-bed alcoholism and drug abuse treatment intermediate care facility in Arundel County. The applicant is Cadencia Incorporated, an existing provider of addictions treatment services in Maryland. These intermediate care facilities provide medically monitored intensive inpatient treatment at the subacute level of care and usually provide both withdrawal management services and rehabilitation treatment. Kevin McDonald, Chief Certificate of Need Division, will present the staff's report and recommendation on this project. Mr. McDonald, please proceed.
Thank you, Mr. Chairman, and good afternoon, Commissioners. I'll start with a little bit of background on addiction, intermediate care facilities for alcohol and drug abuse, which is how we classify them in our state health plan. The American Society of Addiction Medicine categorizes the levels of treatment at varying levels of intensity, with the 3.7 level being medically monitored intensive inpatient treatment. That's the only slice of addiction services that is subject to CON review. The Commission does not regulate the establishment or expansion of lower levels of substance use disorder treatment, such as early intervention programs, outpatient care, partial hospitalization programs, or residential services. Maryland also categorizes providers as either Track 1 or Track 2. Track 1 is facilities that serve primarily private pay patients. Track 2 is defined as a facility that at least 50% of the payment source is from public funds. Cadencia, the applicant in this project, is seeking approval to establish a Track 2 facility. And in fact, I think that their current patient mix is about 85% Medicaid. Also note that there is no need formula in the state health plan for Track 2 facilities, and there's a lack of data reporting and aggregation of utilization statistics statewide, meaning that the applicant has to develop their case with relevant data rather than any kind of formula like there might be in some of the other categories. Moving on to the applicant, it's Cadencia Incorporated, which is a 50-year-old nonprofit provider of substance abuse treatment services. They operate 169 programs at 101 facilities in Pennsylvania, Maryland, Delaware, and the District of Columbia. Four of their Maryland facilities are in Baltimore City, one of which is an intermediate care facility that provides level 3.3, 3.5 residential program in addition to 3.7 withdrawal management services. Cadencia also operates a residential treatment program within the Baltimore County Detention Center, 2 facilities in Arundel County, an outpatient program in Glen Burnie for adults and adolescents, and in the near future, they'll be opening a halfway house for women that will provide level 3.1 facilities, 3.1 services in Crownsville. The application is on behalf of Cadencia Crownsville, a Track 2 facility for adult males. It's a 90-bed facility that operates currently at level 1.0, and then residential services at 3.1, 3.3, and 3.5. Cadencia seeks to add 15 level 3.7 withdrawal management beds and 12 3.7 residential treatment beds to its existing 90-bed facility. Again, it would be a Track 2 facility, predominantly publicly funded and serving low-income individuals. The beds would go into existing space, and there's a small capital expenditure, a little bit over $16,000, for furnishing the rooms. The application meets all of the state health plan standards, and I'd like to particularly call out the sliding fee scale, which is, I think, very aggressive and makes care very accessible. They also have a robust internal data collection process, tracking program completion and readmission rates and other key treatment metrics across all of its facilities. Its last 2 years had a completion rate averaging 56%. You don't often see, well, you don't see a lot of these applications to begin with, but we don't see many that have statistics like that are really keeping statistics like that. And they're not really good benchmarks to compare them to, but I think it needs to be, they need to be given kudos for the tracking that they are doing and sharing within their organization. Looking at need, their current intermediate care facility in the Park Heights neighborhood of Baltimore City cannot fulfill the level of demand it is seeing for this level of care. It experienced a 38% increase in the most recent fiscal year. It's operating at full capacity, actually over capacity, and the number of admissions is growing, literally growing each month, along with an ever-increasing wait list. The Cadencia Crownsville facility added 10 crisis beds in January of 2018 that were immediately busy, and more detoxification capability is required as a next step for those. It's the logical next step for those patients using the service. Finally, in terms of looking at need, the other two Track 2 facilities in Anne Arundel County are running at full capacity with fairly lengthy waiting lists for admission. There are few options to provide alternative. There's few alternative options in the area. Again, the other track 2 facilities in the region have waiting lists. Cadencia points out that providing the opportunity for a patient to immediately enter detox services and treat the addiction is in a medically supervised program is the most cost-effective approach compared to multiple emergency room visits and failed attempts at lower levels of care. They've also pointed out that having the ability to get into these programs, you have to strike while the iron's hot, when the person had just kind of come off the crisis and is more motivated to get into treatment. Looking at viability and financial feasibility, there's a very modest cost to implement the project. Operating costs will increase considerably in order to add qualified staff and support the addition of the 27-bed intermediate care facility program. Total staffing is projected to increase by 23 FTEs, including a near doubling of the direct care staff, and personnel expenses expected to increase by about 1.4 million or 61%. Facility has a recent history of generating a positive operating margin, and that situation is projected to actually be enhanced by the facility's expansion. In terms of impact, although Maryland lacks routine and reliable data collection that can aid the analysis of supply and demand, staff believes that the data provided by the applicant and communications with state agencies and the provider community indicate that Maryland lacks sufficient ICF capacity to fulfill the demand for services by low-income individuals. By increasing the supply of this potentially life-saving service and offering a lower-cost alternative to treatment in hospitals, the impact on the health system can only be seen as positive. Thus, the staff recommends approval of the project. It complies with the applicable state plan standards, and the applicant has demonstrated need for the project, its cost effectiveness, and its viability. Staff also concludes that the impact of the project is positive, primarily because it will improve access to intensive, medically monitored inpatient alcohol and drug treatment services, and that these services will primarily be used by low-income households who are currently underserved with respect to level 3.7 care. We do have representation of Cadencia here today. Regional Director Christy Blaylock and Amber Wiener, the Community Relations Manager.
At this point, I'll entertain a motion to approve the certificate of need application by Cadencia. Second?
Second.
All right, discussion.
Kevin, what's the negative discharge on page 1? Rate of negative discharges, what's that?
Page 11.
Yes.
And the question?
What's a negative discharge? It says they'll monitor the number and rate of negative discharges.
It's the last bullet point.
Representative can answer it.
What section is that in?
In the middle of the 0.05.
Negative discharges. I believe what that is people who have been discharged earlier than the completion of the program. Yes.
Failures.
Just people who didn't complete.
So, other questions, Commissioner O'Connor? Just a comment for the record. The application was initially filed in March 2018. It wasn't docketed for almost a year after that because of problems with the initial application. There's a clear need for this facility, for these facilities. I think we have, in our process, created a barrier to proceeding forward in a rapid fashion in a way that adds expense to these projects and probably at the end of the day doesn't make them substantially better. I'm worried that we really need to look at this process more carefully in ways that allows the applicants to get through this process much more expeditiously than 18 months. 18 months is just I think the public would have grave difficulty understanding why that takes that long.
Sounds good. I'm just curious, what barriers? Just not dotting each I, or?
They were outlined in the document, but if you want to.
We had, first of all, I think we probably had about 60 of these applications in the last 3 or 4 years, and what we've been finding is that the applicants are very inexperienced for the most part. One of the applicants used a consultant, but even in that case, they had a lot of difficulty meeting the information needs that came forward. We've also
That can mean that our information needs are too great.
well, in that particular case, they changed their project multiple times as well. In this particular case, we had no fewer than 5 different sets of financial statistics given to us, and an application that was lacking in its conformance to providing the information that's needed. It is a very old state health plan as well. And I would also note that it was an initiative of the commission to see if we could deregulate these, and the industry objected to that.
I get it, but and I appreciate that completely, and I do recall that. I think the point that we can make is that as we go through these state health plans and update them, figuring out how to make this easier, a lot easier, within the constraints of what the law allows. Obviously, we don't have the ability to change the law, but we do have the ability to change the regs.
I think both staff and applicants would be appreciative of that kind of.
I suspected that was true. All right. Other comments? Hearing none. All in favor?
Aye.
Opposed? None. Congratulations. You have your certificate of need. Agenda item number 5. The study of mortality rates of African American infants and infants in rural areas. Our final report. God willing. Megan Renfrew, Chief of Government Affairs and Special Projects, and Dr. Sandra Quinn. Welcome back. Professor and Chair of the Department of Family Science at the School of Public Health at College Park, will present on the Commission's 2-year study on infant mortality in African American infants and infants in rural areas. This study is a result of legislation passed in 2018 that directed the Commission to complete the study. The presentation is intended to be a final discussion of the study report and follow up to our discussion last month. After the presentation, the Commission will be asked to take action on the report. Ms. Renfrew?
Yes.
Please proceed.
So today I'm going to briefly review background and key findings on the study, not at the level of depth I did last time, but just enough to give folks who were not here last time a little bit of foundation. And I will provide some context. I will then describe the major changes in the draft since you saw it last, so you know what has changed, and then open a brief review of the recommendations, since that is really the important part of what you will take action on, and then open the floor for discussion. That said, please ask us questions throughout. So just as a reminder, this was a legislatively mandated study with 6 required topics that we needed to cover. We approached it by convening a stakeholder work group with a broad number of stakeholders, completing 3 literature reviews, which the University of Maryland School of Public Health did on our behalf, mostly, and inventorying Maryland programs, and conducting interviews related to community health workers. We also did an analysis of Maryland data. Our key findings were that infant mortality rates have decreased over the historical period, but that racial and geographic disparities persist. regardless of geographic area, infant mortality among Black non-Hispanic infants is consistently higher than that of other racial and ethnic groups. The overall infant mortality rate in Maryland is higher than the US rate. This is likely because Maryland has a higher African American population than the nation on average, and that population has higher infant mortality rates. Maryland actually has, if you look just at the Black non-Hispanic infant mortality rate, Maryland's rate for that population is lower than the national average. So we're actually doing well, but there are still big disparities, so we could do much better. In Maryland, we also saw that Black non-Hispanic infant mortality in rural counties appears to be worsening, while Black non-Hispanic infant mortality in urban settings decreased over the past decade and then has sort of flattened out and is holding steady. White non-Hispanic rates of infant mortality are similar regardless of geography. Similar to what we see in the national literature when we looked at data by risk factor in Maryland, regardless of the risk factor, whether that be risk factors related to maternal health, things like hypertension or obesity, or things related to behavior like smoking or breastfeeding, or things related to education status and other socioeconomic measures, African American infants have a higher risk of infant mortality than white infants. So to turn to changes in the graph, in the draft, we got a number of comments last time about the data analysis. So there's a couple of things we've done to respond to those comments. One was we edited the language in the draft to make clear, I think what we all know, which is that correlation is not causation and that we need to be careful about analyzing single factor analysis. We also made the tie between the national literature review results and what we were seeing in the Maryland data tighter so that it's easier to see how the Maryland data supports what we had found in the literature review. We also added a sub-appendix, it's Appendix A3, that has a multifactorial analysis that was done in 2018, because I know some of you had an interest in that level of analysis, and so it gives you, we didn't run that for this study, it had been done before that, but it gives you a reference document that has that level of analysis in it. The report that you saw last time did have a section in it for areas of future study. That section has become more robust, largely because we've moved some elements that had been in recommendations into that area, either because we couldn't get stakeholder agreement on the particular item, or there's one item where the science seems to be changing at this very moment, and so we didn't want to make a recommendation while those things seem to be in flux. There were a couple of changes to recommendations. So in recommendation 6, which relates to breastfeeding, we shifted the focus from baby-friendly hospitals designation, which is a national designation for hospitals that support infant health and breastfeeding, to a focus on Maryland best practices as a minimum standard, and then a baby-friendly hospitals as a second step for those hospitals who can achieve it. It's not that we think the baby-friendly hospitals is a really good goal, but we also heard from some of our stakeholders that it is expensive to implement, and that for rural hospitals that would be a challenge. So this is a sort of compromise that achieves the overall goal of increasing support for standards that relate to supporting breastfeeding. And then recommendation 13, it had previously been recommendation 14, has been clarified. That language has been clarified the whole respect to the permanent council. And I think The reason why it's 13 and used to be 14 is that we took out the old recommendation 11, which had to do with use of progesterone to avoid preterm births for mothers who had previously had preterm birth. That's been moved to the areas for future study because the FDA is going to be reevaluating that science at the end of the month. And so we wanted to let that process move forward, and it didn't seem appropriate to do a recommendation at this time. Any questions about that? Okay. So then, just a brief review of the recommendations. They're arranged in 3 themes: care coordination, expanding and enhancing access and utilization of services, and need for sustained and centralized focus on infant mortality. That third item is the recommendation 13, the permanent council. Within care coordination, there are 7 recommendations. A general recommendation to improve care coordination processes and tools, including improving use of existing tools and electronic data sharing. A recommendation related to using care coordination to address social determinants of health and racism and implicit bias. A recommendation related to professionals who interact with pregnant women and mothers having training in implicit racial bias, so they better understand the impact of bias. And then improving assessment and referral for mental health and substance use disorder treatment programs. Printed out the whole recommendation, so it's 3 pages. Improving continuity of care, including supporting enrollment in health insurance, co-location of healthcare services for families, and better sharing of data, increasing adoption of breastfeeding, and increasing education in the importance of pregnancy spacing. Moving on to the theme of expanding and enhancing access and utilization of services, we have 5 recommendations. Expanding home visiting programs, which we found to be evidence-based, increasing adoption of group prenatal care, increasing use of telehealth in rural communities, investing in health literacy initiatives, and continuing to invest in safe sleep education and increasing investment in safe sleep resources such as cribs or pack and plays for families that don't have a safe place for their child to sleep. And then finally, the final recommendation relates to the permanent council. The goal here is to bring sustained attention to the issue of infant mortality and disparities. We heard from some stakeholders that this work group that led to the study was the 3rd one they've been in over the course of their careers, and they thought that a permanent council could help keep the focus on the issue. They also felt that while the recommendations in this report are strong, they're going to need more clarification to actually be operationalized, and the permanent council can play a key role in that process. The work group also felt that including maternal mortality would be helpful, as maternal and infant health are tightly linked, and disparities in maternal mortality also need attention. The council would foster cross-sector collaboration to improve mortality rates and reduce disparities. So that is my presentation for today. Any questions about the report, the changes that have occurred since we last spoke? Yes.
Questions, commissioners? I think we addressed a lot of questions last. Go ahead.
I've thought about this a lot since the last discussion we had on this. Something stuck with me that Dr. Thomas said. Take a look at the level involvement of a spouse or a male. Don't misinterpret me saying that men know how to care for children, but better than women. But when Dr. Thomas made that comment, I couldn't help but think, is there a lower lower involvement or absentee dads in the African American community that's contributing to this. And it just stuck with me. I don't know if we've looked at that.
So just before you answer the context, and while that was framed in the context of like the caregiving and the relationship, I think it's in the New York Times today or Washington Post, a major story on the like biological, that the father's risk factors are contributing or can contribute to outcomes that's new. So I think that many of the recommendations, at least as they were articulated, are in the traditional settings, prenatal care, women-friendly settings. To what extent are those settings inviting to fathers? It's simply a question that needs to be on the table. And I have another question, but let's leave that on the table for you to address.
I think it's a really important point, and one of the factors that's also been raised, certainly in the work group, but I believe here last time in September, is also the issue of community engagement. And so, yes, there is some association between whether a mother names a father on the birth certificate and risk for infant mortality. So peppered throughout the whole report is a focus on whole families and, in fact, communities. And that I believe the work group felt this way strongly, as in the literature, the importance of that social support, engagement of the family, and engagement of the community is vital. Yes.
And the other observation, again, the recommendations are as spoken, yet there may be illustrative examples. So, for example, the University of Maryland, major report on creating lactation rooms at the university and making it institutional, making it part of culture. I think when you have an opportunity to lift up, here's an example of what things like might look like. Hearing the voices who actually did interviews with real people in Maryland, I mean, the data is good, but having a voice on top of that data can make it more accessible in the legislative setting. And the last thing I'll say is this is a caution for how we look relative to the nation. And that is just in May, CDC released a major report that maternal and infant mortality in the United States is the highest in the developed world. So simply being better than the national average is not good.
Absolutely.
So we don't want to lift that up necessarily as highlighting how great we're doing. As a nation, we're doing very bad. And we need to point that out. For as a nation to be that bad, there's something structural beyond the state of Maryland.
Commissioner.
How come maternal drug use is not considered a variable factor in infant mortality?
It's not that it's not considered, it's that we were limited by the variables that are captured in the birth certificates and death certificates. And so and there's quite a bit of detail in Appendix A, which you actually should have a printout of, I hope, about how we selected factors. And that was a mixture of looking at the literature and then feedback from the work group and then what was available in this single data set that we were using. So that's all of those were factors in how we made decisions. I think,
it's a critical factor, and certainly Megan's absolutely right about the data we have from a lot of statistics. But what was clear in the interviews we did, what was clear from the programs we looked at, and from the work group is the vital importance of integrating care for pregnant women into substance abuse programs. I was listening, with an ear to your previous discussion. And so we do have a recommendation that really speaks to both having training for those providers that are healthcare providers for pregnant women on how to recognize substance use disorder and mental health issues. And then on the flip side, we have recommendations that are related to how to have those programs better learn how to better serve pregnant women and new mothers. So it's vital. That's another place also where the link with the maternal mortality data in the state of Maryland is important, because overdose is one of the primary causes of death from maternal mortality in Maryland. So you have to see these things as linked.
All right, I'll entertain a motion to approve the report. I believe it is due this month to the General Assembly.
November 1.
Motion is second. All in favor? Aye. Opposed? Thank you very much for this report. This is important work for the state, important effort, and we need to continue to track this. I think just the creation of the permanent council, while it's a recommendation, is something we want to track. But as I think we talked about last week, we need to also look further to what other states have done to effectively address this problem, and other countries, to Commissioner Thomas's point, where this is less of a problem.
Mr. Chair, who's responsible for this public rollout? Again, trying to raise awareness. Is that rest of this commission or?
This is a report that's due to the legislature. The legislature at this point needs to make a decision as to what to do next with the information. I think that while the commission has weighed in on this, and its message will get to the legislature that way, if individual commissioners have concerns about this, they should know that this report is coming to the General Assembly. This is HGO. HGO and Senate Finance. So I think that reaching out to individual members of those committees with thoughts that you have would be valuable, and encouraging them to move forward.
And we do plan to do a press release on the report. One of the challenges for the Healthcare Commission is this is not an area that we traditionally have held a lot of expertise in. And going back on how we were assigned, it's probably a story for another time, but we want to push the organizations within the Department of Health forward to elevate them without pointing fingers at them for things that need to be done better. So I think the point about raising awareness is a good one. We want to work with the other groups at the Department of Health in particular. I think there's been some changes in leadership at the department which were not there in 2018, which may suggest to me that it takes on greater importance than it did back then. And clearly the Bureau for Women and Children, vital statistics, certainly the entire apparatus of under the Deputy Secretary for Public Health, they're the key players in this, along with the local health departments. So I have had some preliminary discussion with the Deputy Secretary about how this could be rolled out effectively without blame for any things that which I don't think the report points any fingers at anyone. And in fact, I think we really do a good job of cataloging resources that are available. I think what we do say is better coordination is something we need to consider. We also did not put any price tag on any of the additional efforts that need to be undertaken, which is always something the legislature is going to prod, I guess, Megan on or someone about what this is all going to cost, because things, new investments, maybe.
I take it the press release will be attached to some social media releases, so commissioners can certainly retweet that, repost it, to to increase visibility.
I don't understand it, just, does this come directly from us back there, or does this have Secretary Neal's, is it coming from?
Comes from us.
So he
the
has
General
nothing,
Assembly asked.
he doesn't, they don't comment, they don't do anything with that?
They've had, the department has been involved since the beginning and has had significant opportunity to comment throughout the process.
But the report of the work group is what the General Assembly has asked for with our comment.
And the other part is what you already said very clearly. What follows this, we really don't get into their wonderful recommendations, but we don't put a price tag on them, or even, I mean, we would say Medicaid can increase its rate or something like you do. We don't play any real role in anything but sort of doing good, even though we don't know how the heck anybody's going to pay for it.
That's the job. That's the General Assembly.
That's the General Assembly.
Right.
We don't have to play any role.
We have to play the same role that the other citizens of the state play.
So they could come back and ask us to do that, but the report, I think we have addressed the requirements in the legislation. We recognize that it would be helpful to put price tags on it, but simply the resources were not available to do that at that time. To Chairman Pollack's point, and Megan's point, the department at various levels has been very involved, but it now becomes the commission's report. We are mindful of looking in this area, because we have someone looking over what they're doing.
We did vote on that, correct?
Yes.
Really,
Thanks.
pretty sure somewhere will have a problem with their phone.
And I do want to thank the University of Maryland team, both Dr. Quinn and also Amelia who's here, because they've been tremendously helpful in the whole rest of it.
Thank you.
Yeah.
All right, school-based telehealth work group updated recommendations. Again, a revisit from last month. Nikki Majewski, Division Chief, Health Information Technology, presented the proposed school-based telehealth work group recommendations at the September 19th Commission meeting. The recommendations center on increasing awareness, protecting privacy and security, promoting innovation and accountability, and developing sustainable funding. Commissioners discussed the recommendations and requested staff to include their perspective on school-based telehealth in the final report. Ms. Majewski will review the additions to the final report. Ms. Majewski.
Thank you. Good afternoon, Commissioners. Briefly, I'll just highlight that this new section is on page 1 of the report, which was included in your meeting materials. And this includes the Commission's perspective on the recommendations that we discussed last month. As a quick reminder, this was a request from the Senate Finance Committee in March 2018 for us to assess current policies in the state governing telehealth in schools and to develop recommendations to advance its use in a school setting. And the final report is due by November. Listed here are the recommendations that involve the key categories that Dr. Pollack just mentioned around awareness building, privacy and security, policy development, and funding. The addition of the Commission's perspective highlights the value proposition of school-based telehealth, and it places emphasis that the recommendations are a starting point to address fundamental challenges to diffusing telehealth in schools. It also includes viewpoints supported by national literature about the potential of telehealth to augment schools' capacity to meet a range of student needs as it relates to somatic care, behavioral health, and special education, as well as the interdependency of access to care with educational outcomes. Additionally, the section notes the significance of ensuring the physical well-being of children to ensure safe and healthy learning environments, but how more work is needed to enable innovation and substantive policy change that will allow telehealth to be integrated into the standard of care in a school setting. It's recommended that the Senate Finance Committee consider legislation that calls for the Maryland State Department of Education in collaboration with the Maryland Department of Health to develop a 5-year telehealth innovation strategy plan. This plan should articulate a practical approach to implementing telehealth in schools. And an underlying aspect of that plan is also inspire innovation, enabling schools to leverage telehealth, while also supporting the core principles of a medical home, as well as access to student information available for CRISP. And lastly, the section notes the importance of a permanent funding source in place of grants to further advance and sustain telehealth in our school setting. I will close here, and I'm happy to answer any questions you might have.
Commissioners? Thank you for addressing the issues raised last time. We had a robust discussion last month. So do I have a motion to approve the school-based telehealth work group updated recommendations?
So moved.
Commissioner Thomas. And a second. All in favor?
Aye.
Opposed? Moving right along. Congratulations. Great work. Agenda item number 8. The Commission is authorized by the General Assembly to designate a patient safety center. Did I skip 7?
Cheated. You're done.
You did. My tabs moved.
But I can go quickly if that's okay.
I think that was a message.
You're not Nikki Majewski, Division Chief for Health Information Technology.
No.
Yeah, just making sure. That's what the notes say here in front of me.
Oh, I see.
For a web-based consumer consent management tool. You will be talking to us about that.
That's
correct. Okay. The tool will enable consumers to authorize access and disclosure of their electronic health information. The tool will be developed by the State Designated Health Information Exchange, CRISP, in collaboration with staff. Mr. Sharp, please proceed.
Okay, all right. Good afternoon, everyone. So, I will smooth out the rocky start and talk to you a little bit about what is, to some extent, a goodwill project, but a vital project if we're thinking about expanding the use of the health information technology statewide. My presentation will provide you with an overview of planning activities related to an electronic exchange, health information exchange, consumer consent management tool. The project goal is to design, develop, and implement a web-based application that will enable consumers to authorize access and disclosure of their electronic health information. The tool will support connectivity to HIEs operating in the state, which include EHR systems that have an HIE utility component, or said differently, meet the definition of an HIE in law. So imagine a future state where consumers can use a computer or a smartphone to control who has access to their health information and its use for other purposes such as research. This tool is a vital first step in achieving a future state. Federal policies are aimed at connecting state and regions to support interoperability. Eventually, all ONC certified EHR vendors will connect to a national exchange framework. Generally speaking, national policy promotes consumer engagement. However, it's largely silent on unique solutions related to consumer control of their electronic health information. By way of example, the 21st Century Cures Act promotes interoperability and consumer engagement. Consistent with the Cures Act, in early 2019, CMS and ONC issued proposed rules to support information sharing. ONC's approach is generally focused on nationwide interoperability through national exchange frameworks and use of electronic health information. CMS is supporting the My Healthy Data initiative led by the White House Office of American Innovation, who aims to give consumers more control over their health information. Almost all HIEs across the nation operate on a consumer opt-out basis.
consumers must take steps to notify an HIE if they want to opt out of information sharing or back into information sharing. It is a process that requires consumers to actively get involved in order to make that change. More than 100 HIEs exist nationally, approximately 10 HIEs operating in Maryland. As a reminder, CRISP is the state designated HIE. SAMHSA is an early pioneer of technology that allows consumers to control access to their electronic health information. In 2011, SAMHSA contracted with FEI Systems, a consulting group located here in Columbia, to develop a web-based application called Consent to Share. The application complies with federal and state confidentiality and privacy laws and enables consumers to consent to sharing information through a web-based portal. The source code is made available to developers at no cost. Lessons learned from SAMHSA's innovative effort will inform activities related to this initiative. Staff plans to work collaboratively with CRISP and other stakeholders to advance the work associated with this tool. For the tool to be accepted by consumers and providers, it must be user-friendly. It must be a user-friendly application that can be integrated with HIEs and select EHR vendors that are operating in Maryland. It must also support new and innovative use cases that are yet to be imagined. To guide the work, staff identified several key principles that will help the effort stay on course and enable better decision making. The tool will be developed using open source standards to support widespread system connectivity and alignment with provider workflows. Collaboration with stakeholders is essential to inform all phases of the work. The tool must include a robust privacy and security framework and undergo exhaustive user testing. Stakeholder input in developing an awareness and education strategy that will provide consumers and providers with knowledge about the tool that builds trust and value is essential. Turning our attention to the activities timeline, project planning is commenced. CRISP Technology Committee will begin work on developing the tool's functional specifications early next year. Staff's advisory work group, the HIE Policy Board, begin to consider policy-related matters pertaining to the tool early next year as well. A prototype is anticipated in late 2020. Go live with various demonstration projects are anticipated to begin in early 2021. Development of the consumer and provider awareness strategy is anticipated to begin in early 2021. And lessons learned from the demonstrations will help consumer groups, be used by consumer groups to guide the awareness efforts of the initiative. So, Commissioners, a brief update. This concludes my presentation on planning activities for the tool. I would be pleased to answer any questions you might have at this time.
So I'm a consumer, okay? And I want my information to be shared. Is it only my Maryland health information in the CRISP data set, or is it the information at the hospital end? Or is it both?
So it's actually both, because while CRISP has registries and some data that they include in its infrastructure, it also acts as a pipeline that connects endpoints. So it's able to pull information from the endpoints and pass it through the pipeline. So it's a little of both.
Okay. So it doesn't matter if my hospital has Epic and another hospital I go to has a different. Cerner. So it doesn't matter.
So it
talks to all these things.
It will. So there are two things. The consent management tool allows the individual consumer to mitigate the flow of that information. And the other thing that you're talking about is the interoperability of different solutions to talk to one another. And that is being solved in part by CRISP, but also by the work of the CURES Act, which is the ONC's efforts to create national exchange frameworks, where eventually all EHR solutions will connect to both these community-based HIEs, which is essentially, CRISP is a little more regional, but it will also allow these vendors, these certified EHR vendors, you mentioned Cerner and then Epic, to communicate through these exchange hubs nationally to move to follow where the patient travels.
It's the last thing. I heard what you said. It's very complicated. How much confidence do you have this is going to work?
So I have the same confidence with this that I did in probably 2007 when we started planning for HIE in Maryland. And well, I think we have a long way to go. I don't think I could say I would have to say I'm very pleased with where we've come to since 2007. I would have never imagined we'd get this far. This tool reminds me in some ways of the planning we started back then, because it will start the wheels turning, and with innovation, the more people who get on board, the better the idea becomes. And so we act as the seed for innovation, and then smarter people than us will begin to add and shape it.
Thank you.
That's just a slightly different perspective on that. I mean, in 2007, I was pretty convinced that we wouldn't get here. And we did in a very functional way. And it gives me great confidence that something like this is much more achievable.
Thank you, Mr. Chairman.
Thank you. All right. Now, item number 8. 7 goes first. Forget that. The Commission is authorized by the General Assembly to designate a patient safety center for the state to foster a culture of safety among healthcare providers. Teresa Lee, Director of Quality Measurement and Reporting, will provide an update on the status of the designation process and proposed recommendations for Commission consideration. Ms. Lee.
Mr. Chair, Commissioners. What I'd like to do today is provide an overview of the Patient Safety Center and provide a background, because the designation process comes to an end at the end of December 2019. So we'll be in the position to do another 5-year designation for the entity that we believe should serve as the Patient Safety Center for the state. So let me just give a background first. And please stop me at any time if you have questions or if something is not clear. So I'm going to talk about the Patient Safety Acts of 2001 and 2005, the role of MHCC and HSCRC in those 2 acts, the role of MHA, and then what we're proposing going forward. So it's been almost 20 years since the establishment of the state level of the Maryland Patient Safety Act. And it basically creates a patient safety center for Maryland to be designated by the Maryland Healthcare Commission. And part of the act provides the authority to the Patient Safety Center to function as a medical review committee, to give them medical review committee status, so that the information, the data that they're discussing, it remains inadmissible and confidential. In 2001, there was a study. 2002, they recommended a 3-pronged approach. One was what I just described, the ability to collect information on adverse events resulting in death or serious disability, but also allowing providers, physicians, and others the opportunity to discuss that information in private without the concern of liability or admissibility in court, so that they could facilitate that type of discussion. This act also promoted the voluntary reporting by hospitals, nursing homes, and other facilities of these adverse events and near misses, and to promote greater provider education to hopefully eliminate or at least reduce adverse events. And then to promote a data system and technologies to improve care. In 2003, the Maryland General Assembly gave Maryland's Patient Safety Center medical review status, which I just mentioned, so that they would not be admissible. At the national level in 2005, a similar act became law, and it established patient safety organizations nationally. It was implemented by ARC, the Agency for Healthcare Research, and the goal of the PSO is to improve quality and safety by reducing the incidence of events that adversely affect patients. So you can see that there's similar acts that are going on at the federal and state level. The Mid-Atlantic PSO was designated by ARC as the PSO for Maryland. And the Maryland Patient Safety Center, which is our Maryland Patient Safety, official Maryland Patient Safety Center, is a parent organization of a component Mid-Atlantic PSO. I think it's important to make the distinction between the MPSC, when we talk about the Maryland Patient Safety Center, which is part of the act that gives us the authority to designate an entity every 5 years. And then the Maryland Patient Safety Center Inc., which was created by, I believe, the Maryland Hospital Association to serve as it is actually the parent organization to the Mid-Atlantic Patient Safety Organization, but they actually serve two different acts. And I know it's a little confusing. It's been confusing for me to gather up this history. The ARC designation of a PSO, in this case, it is the Mid-Atlantic PSO, which is a component of the Maryland Patient Safety Center, Inc., expires in October of 2020. The role of MACC and HSCRC in this initiative, the Maryland legislation that created the Patient Safety Center for Maryland provided no funding, so HSCRC agreed to provide the funding, seed funding, to support this initiative when it was first established. This is seed funding through hospital rates. So it's actually patients who have gone to hospital, there's a slight adjustment to the rates that form the basis of what they pay. That's the source of funding for the Maryland Patient Safety Center, Inc. MACC was given responsibility for designation, as I've mentioned, for a 5-year period. And in October of 2003, MACC issued a solicitation to establish and maintain the Maryland PSC. In January 2004, it was awarded to, the contract was awarded to MHA, the Maryland Hospital Association, and Delmarva as a collaborative to implement and operate Maryland's PSC through 2009. So that's the first 5-year period. The role of MHA during that early period, MHA and Delmarva, as I said, collaborated to form the PSC, and that affiliation between the two was in part an attempt to align the Maryland Patient Safety Center with Delmarva, which was the QIO at the time, and the services and programs of the QIO, and the Patient Safety Center physical location was at the Maryland Hospital Association, and it continues to be that way today. So in 2009, the entity that is the Patient Safety Center, that was the Patient Safety Center, incorporates and takes on the name of the Maryland Patient Safety Center, Inc. So when we talk about the Maryland Patient Safety Center, it is as a Maryland affiliate, and a Maryland entity to satisfy the Maryland 2001 requirement, and the Maryland Patient Safety Center, Inc. is an entity that serves as that. So it's the same name, but it's slightly different. And I apologize if it's a little unclear. So in 2009, there was a redesignation or a designation for the second 5-year period. But the commission also released a public notice and a request for expressions of interest to see if there were other entities that wanted to be the PSC for Maryland. That was published in our website, on the commission's website.
Were there any expressions of interest?
Right, well, I had that line, but there were no expressions of interest at the time. The MACC, based upon the review of its the report from the Maryland Patient Safety Center.inc decided to redesignate the entity for another 5 years, and that would take them through 2014. And then there was another designation for 5 years. I won't go through all this, but there were some concerns at the last designation during that process from the commission and from other entities generally. And the commission staff put together an MOU to try to firm up what our expectations are of the Maryland Patient Safety Center. And these are just 4 areas. One is that they needed to provide more detail on their current and proposed collaborations, programs, and education initiatives. They would provide semi-annual reporting to the commission on its operations, and any statistics and trend data to show us whether or not there was an impact, whether there was some positive outcome from the various programs. And then we asked that a member of the commission or staff be placed on the board of directors so there'd be additional engagement. And following the implementation of that MOU, the commission agreed to redesignate the Maryland Patient Safety Center.inc for another 5 years through December of this year. So moving forward, Maryland Patient Safety Center.inc is looking for a new president, new leadership. Robert Imhoff, who presented 5 years ago, you may recall, has gone, and they're still looking for someone to replace him. In May of 2009, well, in this past May, HSCRC approved funding for fiscal 2020 for the Maryland Patient Safety Center, and their funding is decreasing with each year, and they're down to about $369,000 from HSCRC through hospital rate adjustments. We have been working with the Patient Safety Center staff as they wait to hire a new president. And we do have some information on their performance over the past year or more. And we will have that available to you next month. But we wanted to at least raise this issue now since the designation ends in December. And we have 2 recommendations associated with this project. One is that we release a request for expressions of interest, to see if there is interest from other entities who would like to serve as the state's ESC. And to enable us to do that, as well as to look into what's going on at the federal level, what's going on at other states surrounding patient safety center activities and the ARC designation, redesignation, we would like to extend this current designation period for 120 days to permit further review. So that's all I have, and I'm happy to take questions. I know that it's a bit confusing with the MPSC 8 versus MPSC, but
Let me just to clarify, since we have a recommendation to release the RFI and to extend the designation period for 120 days, why don't we take a motion to adopt the staff recommendation? Motion in a second. Good. All right. Discussion now. Questions for us on this process?
So you mentioned that maybe, make sure I'm clear, open up the competition. Okay, let's talk about the current incumbent. I remember when it came to present. Who had the award before they did?
they've always had the
So
award.
they've always had the award. There's always an advantage to an incumbent without the history. Do you believe that there are, at least this would go to a state entity, correct? Not an out-of-state entity?
That's a good question. I would assume it is a state agency, but does it have to be?
Okay, so this should be open nationally. Anyone in the
Right. Who wants to establish this patient safety center focused on Maryland data?
correct?
Now, just to be clear, there is no more funding, we could still negotiate with HSCRC to see if they wanted to provide seed funding again. But the original ideal is that the funding would decrease over time. This would be seed funding through hospital rates, and that they would sustain the patient.
What's in front of us right now is a proposal to release an RFI,
Yes.
through which process we could learn what would be necessary to make this as competitive as we feel it needs to be, to address your point.
And therefore, it helps knowing that it's going to be national, potentially. And then I'll ask you this, other states have patient safety centers, yes?
Yes.
And is there, among the states that have patient safety centers, is there a best practice? Is there a model, an aspiring model, Peter? Or are we the people?
I can't tell you that yet because we need time to actually do that type of review. That's why we're asking for the 120
Landscape in
days.
2014 is not the same.
Yeah.
Okay.
I mean, ideally, we would be able to, if we were working throughout as staff and recognizing that they had not submitted that last report and gotten the report, and we could have done this a little earlier, but unfortunately, we're at this stage, which is why we're asking for additional time to really investigate appropriately instead of trying to designate again the same entity, but to really determine, because there are some informal comments and concerns about their performance. So this would give us time to really try to quantify that.
I think you and I may be the only holdovers from 2014 still here, but there was quite a bit of concern at that point that we raised about the effectiveness of the organization and the opportunity that might exist to do more. And I think this process will give us a comfort around answering that more robustly than we've seen so far.
Where do they put aside the seed funding? Where do they get their money? Outside of the seed funding, which I understand.
Well, most of it originally was HSCRC, but it's decreased down to about, I mean, it's about, as I said, 370,000 out of a little over $1 million. So they do get revenue from an annual conference that they do. I think that's about 200,000. There are funds that they get from fees from some of the services that they provide. So there are other sources. There is a perinatal collaborative that was historically sponsored by or funded by the health department. So there are some discussions about that right now.
Does MHA still provide some support to them?
I didn't see, I looked at the budget yesterday, and I didn't see MHA on there, but I can check. I don't want to say they don't. But they do provide the location, as their offices are at MHA.
One thing we may want to know is if we're putting out an RFI and there are national organizations that do this, are we setting up the conditions in the state of Maryland for success that other states have had? In other words, in terms of what these entities could do, or okay, so we're going to explicitly ask for those kinds of proposals.
Yeah, we're requesting information that would inform a proposal.
Because if we have a rule that keeps other people out of the state somewhere, that's what they can do it.
And the fact that there is the ARC designation process that they do at the federal level, and so the Maryland Patient Safety Center.inc has that designation until 2020. So there are a lot of moving parts with this that we want to spend some time so that we can provide a better recommendation of how it should go forward.
So I think there are some 80-odd patient safety centers recognized by HRQ. So obviously in some states there's more than one. That has been a historic stumbling block that the commission in the past has kind of wrestled with. But I don't think it's necessarily, we think that the HRQ and the state patient safety center being one and the same. Ideally, it would be better, but it could. The function and roles are a bit different, as Teresa pointed out earlier.
And the quality staff has begun to do some research, and they identified that there are 87 ARC-approved PSOs, patient safety organizations. So there are a number of them out there. I don't know how many states, but at least 87 exist right now.
Very good. So I have a motion on the table and a second to approve staff recommendations to release an RFI and to extend the current designation period for 120 days to permit further review. All in favor?
Aye.
Opposed? Thank you very much, Teresa.
Thank you.
Agenda item number 9 comes after.
That's correct.
Ben, would you like to share the upcoming activities for November's public meeting?
We will maybe repeat those numbers in French first to make sure we're all. No, the November meeting will include, as I'm advised, several CONs. Advised not to specifically call them out, but one would likely be a hospital CON. We'll have trauma recommendations. Trauma report is due to the legislature in November, so we'll want to present that to you. We've also asked the executive director of MIMS, Theodore Delridge, Dr. Theodore Delridge, to come and present his vision for MIMS and how the two committees, MIMS and NHCC, can work together. In September, Commissioner O'Grady asked for some additional updates on hospice utilization. The staff has gathered the hospice survey results and will be presenting that. And we've also got a request from the from the hospice network to present at the same time. So we've agreed that they could provide their views on the commission. We intend to provide an overview on the telehealth grant. As I mentioned earlier, we anticipate this large telehealth grant that would take advantage of experience learned over the last several years to really put a stake in the ground to establish a pretty large initiative on telehealth. And then lastly, as is required before the start of the year, Ken will present the Maryland Care database requirements that we release to the payers prior to the start of the year. That's something they need, a technical document they need, data specification for submitting information to us. So that would conclude the agenda at this point.
So just one clarification on that. I asked Dr. Delbridge from MIMS to talk about a bunch of issues where we intersect, but in particular about emergency department wait times and the challenges that EMS units are facing statewide with access to emergency departments. I think that in the context of the total cost of care model and importantly the GBR tool is used to achieve the goals of that model, it's incumbent upon us to make sure that we're actively measuring access to care. These types of models have in other areas, and they say these types of models because there's no exact use of this model elsewhere ever in the world. We are a leader in that regard. But these types of models have been in the past associated with limitations in access to care. And a stress point for measuring those is emergency department access. So I think it's important for a series of reasons, that included that we continue to monitor carefully the stress points to make sure that the citizens have the access to the care that they need. That the experiment in population health management is not leading to any limitation on that access.
Mr. Chair, just very briefly, there's kind of a natural experiment going on in the state. Not in love you're describing, but in Prince George's County in particular, almost 900,000+ residents. We have the new Capital Region Health coming in. We have dentists. That vital facility overlaps into Prince George's County. We have Children's Hospital. I mean, so all of a sudden, in the time you and I have been on this commission, huge access in that county.
And Arundel merger with doctors.
The Arundel and doctors. So are
Huge
we
changes
watching?
without question.
Are we watching this? Is there an opportunity to monitor whether this new access improves health outcomes?
So the point you raise is one that I think about and worry about a lot. that when you ask whose job it is in the state of Maryland to monitor that access to care and monitor the degree to which the changes that are occurring in the market represent a threat to access to care, you would say that if anybody is charged with that, it's us. If anybody is certainly poised to evaluate it, it's us. We have limitations from a budgetary standpoint, from a scope of work standpoint as to how much we can do when. But it's definitely, that is something we should be paying attention to, paying careful attention to. And, you know, I feel like I'm being the nasty guy when I fight back and say we're spending too much time on CON issues that don't require it, and or that where we could do something simpler to repurpose that effort in areas in ways that ensure that we are the oversight body for access to care. To me, that's important. That's what we're here to do, and to the extent that we can.
Huge change and tremendous opportunity to answer the very question.
I agree. Other comments? I will accept then a motion to adjourn, if anybody's so inclined. That was the most enthusiastic, and I believe you made most of the motions that I asked for today, Commissioner Hammerslot, but that was the most enthusiastic. Is there a second?
Second.
Yes. All in favor? Aye.